was a bit challenging and a bit complex is because the patient's ear canal entrance is completely collapsed, meaning obtaining entrance to the ear to remove this plug of skin and wax was very, very difficult for that particular reason. Now, some elderly patients, as we age, the cartilage, similar to what the tip of our nose, it weakens over the years, and then gravity has its effect. So some patients come in with a collapsed ear canal entrance. That's because the entrance of the ear canal is made of cartilage, whereas the inner 2/3 is made up of bone. So it's more rigid, it holds its shape over the years. Similar to some patients, as they age, they develop a droopy tip, droopy nose. And in the case of the ear, the cartilage, so the posterior canal wall, so this is the back part of the ear canal which extends to the entrance of the ear, it can weaken and collapse upon itself, and it almost creates like a trapdoor scenario. Nonetheless, with an endoscope, we're more than able to stretch this ear open and remove the wax, and you will see that before. What we do, I pull the ear back. So because the outer part of the ear is cartilage, you just see me there, I've just lifted this ear open. I insert the endoscope into the ear, and the endoscope acts like a doorstop, and it keeps the ear canal widened and stretched, so I can insert the microsuction probe. There we are again. And with that technique, it doesn't really matter how small or narrow an ear canal is. Once you've developed the endoscopic technique to do that, we can perform the procedure in any ear, really. It doesn't matter if it's swollen, bendy, twisty. We actually not only widen the ear, but we straighten the ear. So the ear canal is like an S-bend. And when we stretch the ear open, we straighten the first bend so it's in line with the second bend, and it just creates a cylindrical straight tube from the entrance of the ear to the eardrum, so we mitigate the bends. So I've removed the occlusion. Now this is where the patient's got a layer of dead skin that's coating the medial part of their ear canal. So when we say medial, we mean towards the eardrum, so further away from us. And I'm just using a fine suction tip here, and we're trying to just lift this up. Now the reason for that, now the procedure itself is in some ways complete. The patient can hear it. Well, I correct myself there because the patient has actually got glue in. I'll come back to that a bit later. So despite the removal of the blockage, the patient's still not able to hear very well because they've developed glue here. But I'll come back to that in a moment. Now with this dead skin, it's not going to improve the hearing any further. However, this skin is not going to migrate on its own. This skin, it's almost like double-sided sticky tape. It's stuck itself onto the canal wall, and unfortunately, it's not going to migrate. This skin will just kind of eventually develop into a skin plug, which is what the patient came in with. So another skin layer will die and shed, and it will add another layer to this already thickened layer, and it will just get bigger and bigger and bigger until it forms a plug in the ear canal. With skin that is this strongly adhered, you do get some blistering on the ear canal, unfortunately, and you will see that. You can just see how narrow this ear canal is. I'm stretching it open. I think I'm going to use some forceps in a moment. Maybe not quite yet, or am I? Let's see. No. So I just want to lift this away from the ear canal a bit more, and the reason for that, because the patient's got a narrow ear, I want to make sure the skin is positioned in such a way that if I'm not able to suction it off, peel it off, that when I do insert the forceps, I can safely insert the forceps. So the jaws, the two jaws of the forceps are clasped around the dead skin without making contact with the canal wall, because that's really important, because when the bony part of the ear canal now, we want to avoid making contact with the bony part of the ear canal. It still amazes me sometimes when I listen to, or I get advised of some of the comments that why don't you use this instrument deep in the ear? And the reason why, if you've been watching my videos, I've tried to explain a number of times that the inner 2/3 of the ear canal is very, very sensitive, and if you make contact with that, believe you me, you want it to be your ear and someone making contact with the inner 2/3 of the ear canal. So that's the reason why, guys. So we're not doing it for any other reason. We're doing it for patient comfort. I don't use any anaesthesia. I know some specialists that are online use local or general anaesthetic, and then you can be a bit more aggressive with the ear, but our patients are awake. We're not going to administer, as an audiologist in the UK anyway, we're not allowed to administer any anaesthesia, but we don't really want to administer any anaesthesia for what is relatively a short procedure, generally speaking, is earwax removal. So again, I just lifted this dead keratin off the base of the ear canal, which then enables me to insert the jaws of the forceps either side without making contact. I'm slowly bringing this forwards. You can see when it comes out the entrance, it's really narrow there. Now that's the patient's eardrum in a moment, and it's very dull. It's retracted, so the hammer bone, the short processor, the pointy bit at the top, it's prominent, which means the eardrum is generally retracted. It's sucked in and it's wrapped around. Think about the eardrum like a piece of cling film, and you've got this cling film on your lips, and you suck inwards, and the cling film will then wrap around your lips and possibly your teeth as well, and it's similar to the eardrum if it's sucked in. So there's a tube behind the eardrum called the eustachian tube, which connects the middle ear to the back of the nose. The eustachian tube is a pressure equaliser in the ear. We want the air pressure behind the eardrum to be equal to the air pressure in the atmosphere, and when the air pressure is equal either side of the eardrum, that's when our eardrum is most compliant, most mobile, that's when we hear the most. And it's a function of this tube that connects the back of the nose to equalise the pressure. That tube is generally closed, and it opens very briefly, momentarily, when we swallow, yawn or chew. And during those brief moments when the eustachian tube opens, the air can equalise itself. Now, this eustachian tube not only acts like as a pressure equaliser, but it also acts like a drain pipe. So any fluid behind the eardrum, it can trickle away and drain out of the eustachian tube to the back of the nose. But if the